Yeah. I think we have gone live. We have started live. So thank you very much once again for examiners, the candidates, and my dear presenters, and of course our attendees. Now, without you attendees, this program is not going to be a success. This is our seventh continuous program, and every time we have got around 50 to 150 attendees. The last time was maximum. I think we touched 167, probably depending on the topics which we get, also the timings. We specifically pushed this program this particular day because a Diwali program was coming up and also an East Zone conference was there. Now we have two wonderful examiners as we always have. Dr. Ranjan Kumar Dey is from Shantiniketan Hospital, West Bengal. Dr. Ranjan Kumar Dey was the former head of Department of Urology in Arjikar Medical College and is currently the president of the East Zone Association of Urologists. And more importantly, he has been traveling as an examiner to South a number of times in the last years. So there is very likely the university might call him again also. So please be prepared with these questions. You can note them down, the questions and answers. Along with him, we have young and enchanting Dr. Prasant Adiga, who is the head of Department of Urology from Father Muller Medical College. There was one instance where I had an opportunity to share a program with Dr. Prasant Adiga. This was an exam actually in last year. And his questions and the way he was asking so wonderful. I thought he is a very apt candidate for these master classes as well as an examiner for these online programs. Thank you, Dr. Prashant, for consenting to come with us.
Thank you.
We have Dr. Mohammed Salman, who is going to be the presenter today, and Dr. Surendran, who is going to support him. We have two candidates, Dr. Murugesan from Madras Medical College and Dr. Hafsa from SRM Medical College, Katangadatu. So as we know, we usually give the diagnosis much before, so it's much easier for you. The diagnosis today is stone disease. Mohammed Salman will be presenting. Dr. Hafsa will start the discussion with Dr. Prashant. Please go ahead, Dr. Hafsa and Prashant.
Thanks.
Yes, Salman, you can start presenting.
A 60-year-old lady presented with complaints of left loin pain for 15 days. She had a history of one episode of hematuria without any clots. She also had 1 week of burning micturition. No history of LUTS, no history of pyuria or calcaluria, no history of fever or vomiting, no history of loss of weight, loss of appetite, no history of trauma.
Sorry to interrupt. Just make it slideshow mode.
Full screen.
Shall I move to the next slide, sir?
Yeah, you make it.
You go ahead with the next slide.
Yes.
Slide.
Past history, no history of prior surgeries except PS. She is a known hypertensive on treatment.
Sorry to interrupt you, sir. Slides are not.
Wait. Can you open the slideshow? It is not showing the slide.
Yeah.
Now it's moving.
Go to the first slide.
Yes, sir.
Please share once again and share entire screen, sir.
Share your screen so that we can see. Yeah, next slide. Yeah, keep it. Yeah.
You start it once again because we could not hear you very clearly. Now it is okay. You start.
Yes, sir.
Okay.
A 60-year-old lady presented with complaints of left loin pain for 15 days. She had 1 episode of hematuria without any clots. She also had 1 week of burning micturition. No history of LUTS, no history of pyuria or calcaluria, no fever or vomiting, no history of loss of weight, loss of appetite, no history of trauma.
Yeah, stop here. Any other history you want to ask, Hafsa?
Sir, I want a little more elaboration on the hematuria.
Okay. Nothing with the loin pain?
Loin pain also, if I could get any information of how it, of the type of pain, of the details of the pain, sir, if it was intermittent, if it was continuous, if it was radiating, any details on the pain, sir.
So he's telling that left loin pain 15 days. So what exactly you want to know in the pain? Whether it is a dull aching or a
colicky pain or a dull aching pain. If it is a continuous pain or it is an intermittent pain, if the pain is radiating anywhere, if the pain is aggravating or getting relief by medication.
See, why dull aching pain is important? Why it is, see, why not this thing, colicky pain? Why dull aching in this patient? 60-year-old female, dull aching with hematuria, one episode. What is your first thought?
The hematuria it's a continuous terminal. I want the details of the hematuria, sir, if that is possible.
One episode, no clots.
Total hematuria.
So what is your first diagnosis when you ask 60-year-old female with the left loin pain and with hematuria, one episode?
The first diagnosis, it's acute onset. So I will think of stone disease as my first diagnosis. I will also think of renal malignancy, considering her age and hematuria. But then it is one episode and there are no clots.
See, the problem is here is he has told about the flank pain, but whether it is a colicky, whether it is a dull aching, it is not differentiated. Whether it is associated with vomiting or not is not mentioned. So automatically 60-year-old female presenting with a flank pain with hematuria, our first diagnosis should be
Malignancy.
malignancy. It should be a malignancy. Then is the second is a stone disease.
Yes.
Okay. And how will you explain a burning micturition in this patient?
So concurrent UTI can be present, female.
Okay. If there is no UTI, any other thoughts?
If it is a stone disease, it can be a infected stone which can cause.
Yeah. Rather than that, where you will get a dysuria in a stone disease?
It's a bladder stone mostly, sir.
Rather than bladder stone, with the bladder stone won't be associated with the flank pain.
Flank pain, correct, sir.
Any other stone which can cause dysuria.
Anything between the bladder and the
Any ureteric cal or.
Not all ureteric stones.
that specific sir is asking which specific part of the ureter.
Which have burning.
Can
A
produce-
VJ cal, sir. A VJ cal usually.
Yes. Why there is dysuria in Vujay stone?
Because of the mechanical obstruction of the passage of urine, sir. Patient, there is obstruction of the flow is obstructed, so it gets infected, and the patient then starts getting pain.
Madam, can you define what is dysuria?
Painful pain during micturition, sir.
Yes. Why there is pain during micturition in the Vujay stone?
Sir is asking, does the stone produce an inflammation in which part of the bladder then?
It is usually in the trigone area that inflammation is there. So
And what happens during micturition? There is trigonal spasm.
Yes.
And the ureteric orifice opens into the trigone. So it is a continuous extension of the symptoms. It is producing inflammation in the lower ureter, also in the trigone, and that during the micturition, when there is trigonal contraction, there is more spasm there. Okay, sorry.
Yes, Prashant. Yeah.
Hematuria can cause dysuria?
Yes, sir. Hematuria can also cause dysuria, sir.
If you are thinking of UTI with the stone, what type of stones you are suspecting?
Infective stones, sir. As first, any stone, for that matter, can cause UTI. But I will think more in patient also has loin pain, so I will think more in favor of renal pelvic cancer.
Move to next slide.
Past history, no history of prior surgeries except PS. She is a known hypertensive on treatment with tablet amlodipine. She is a known case of rheumatoid arthritis on tablet methotrexate, hydroxychloroquine, and folic acid.
Chloroquine. Anything?
Hydroxychloroquine, yes.
Hydroxychloroquine. Anything?
The,
Urologically has got any significance?
yes, sir. It is a indirect promoter of stone formation.
More than that.
Methotrexate, he is asking that for methotrexate, do you have any concern?
Yes, sir. Methotrexate also by itself can uh, cause crystallization and eventually stone formation, although rarely, but it is a cause for stone formation, a drug which can aggravate stone formation.
Chloroquine can cause change in the color of the urine.
Yes, sir.
That is also is important. So you told hematuria. You don't know. So exactly. That is why. Okay. Yeah.
Personal history, she is a mixed diet consumer, no significant family history. General examination, patient's conscious oriented, she is moderately built and nourished. Her pulse and BP are normal, she is afebrile. General examination revealed no pallor, icterus, cyanosis, clubbing or lymphadenopathy. Systemic examinations were normal. Abdomen examinations, inspections, all quadrants moves equally with respirations, no distension. Palpation normal, percussion, auscultation tend to be normal.
Anything you want to specifically examine in this patient? Flank pain?
Flank tenderness, renal angle tenderness I want to see, sir.
Okay.
And any fullness is there in the flank if I am, because I have not ruled out malignancy.
Okay.
When
You want to percuss the renal angle?
Yes, sir.
What will be the normal note you hear in a percussion of renal angle?
Dull note, sir.
Dull.
Resonance, sir. It is.
Sir, can I ask one small question?
Yes, sir.
Yeah. So, can you just tell me the boundary of renal angle?
Sir, it will be the 12th, the angle of the 12th with the
Any muscle?
psoas major, sir.
Cross.
No.
Psoas.
Angle, it will be.
You have a 12th rib above, you have an iliac crest below. There should be something in the midline, which is next to the spine.
Erection.
I'm playing internal roles. Something should be para.
I have seen this, I have noticed. Many of us utter a word, but without knowing the exact significance of it. Isn't it? You just tell me why renal angle is tender and what is the importance of the renal angle.
Sir, renal angle, it will become tender anytime there is an inflammation of the kidney, sir. So, in this patient, I have not ruled out chronic pyelonephritis. It can be considered, or if the patient is having current inflammation because of the stone itself, again renal angle will be tender, sir.
Dr. Afsa, actually, you have not summed up your differential diagnosis to Dr. Prashant. I think all through your discussions, it was only a stone disease and then malignancy and UTA. Is there anything else you want to say to Dr. Prashant?
Sir, other rare causes of loin pain with hematuria, I have not ruled out any cystic disease, polycystic kidney disease, PUJ. Considering the age, it is rare, but as my last fifth or sixth differential, I can consider for PUJO also, sir. But age group does not fit, sir.
The UPJO can present even it is intermittent obstruction. Patient can present in the later this thing. See, that is what the renal angle percussion will make a difference. If there is an hydronephrosis, usually it is tympanic because of the colon band. So it becomes dull when there is an hydronephrosis. Okay, it pushes the colon, so that is why you feel a dull note there. Okay.
Apart from the short duration of presentation, Patient coming with a left loin pain, 60-year-old, and also a lower urinary tract symptom. Can the candidate say genital tuberculosis is also one of the differential diagnoses in this patient?
Due to
If
be
you control the short component of the acute component of the pain.
the but again the problem is, sir, here is there is no other urinary symptoms. Most of the time they will have some symptoms, and 15 days is short duration to say it is a GUT.
And
Can I
GUTB has
say?
an insidious is it's an insidious presentation gradually, because irritative symptoms are more initially than this acute pain. Acute pain in GUTB is a quite unusual presentation, first presentation.
So can I say TCC also?
Yes, I was expecting that you will say TCC. And the hydronephrosis can occur due to pelvic TCC, isn't it? And there can be hematuria also. Like the stone, first differential diagnosis clinically comes to you is TCC. Okay?
Yeah, Hafsa, can you give the differential diagnosis in the order now to Dr. Prashant?
It's the first is RCC, TCC, renal calculus, uh, cystic disease of the kidney, uh, PUJO, and last, if the patient has a history of TB, although they're not mentioned, CUTB as the last.
Anyway, the examiners have not agreed of genital tuberculosis as a part of the differential diagnosis. It may come to you as a course of investigations, but not as a part of differential diagnosis. Anything which is not a part of the differential diagnosis, we will not do those specific investigations. Like in this case, we will not go for an urinary AFP unless there are any other features that suggest. So your first five differential diagnosis, I think Prashant looks fairly good enough at this particular stage for you. Um, so at this stage, shall we go for the investigations, Prashant?
Yes, sir. Yes, sir.
Investigations, may I request Dr. Murugesan, can you join us for the investigations? Ranjan sir, you are on for the investigations, sir.
Okay. So whom should I ask?
Murugesan?
Sir.
Mukesh, where is Mukesh? I can't see him.
Yes.
Is he online?
Yes, sir.
Yeah. Okay. With this patient, may I ask you that you are on-call resident, you were asked to examine and you have got this finding. After that, what is the first thing you will do to the patient?
Then, as an extension of clinical examination, I want to do ultrasound JAB for this patient, sir.
First of all, you should give relief to the patient by
Yes, sir.
yes,
By,
he's a human being. You will have to treat a human. So first of all, you have to relieve the pain of this patient. Okay.
Okay.
To never
Yes,
make
sir.
this mistake.
Yes.
Next, how will you write your diagnostic approach? What will be your diagnostic approach?
Then I want to do USG ultrasound JAB for this patient. See bedside clinical examination. I want to.
Tell us. Only ultrasound examination you will do, nothing else you will advise for this
Then
patient in acute
urine
phase. Huh?
analysis.
Murugesan sir is asking you, you selected to
Yes, sir.
do an ultrasound examination rather than a routine urinary investigation and bed investigation. What is the reason
Yes,
for
sir.
doing an ultrasound examination? Do you want to taper your investigations following your ultrasound, or is it because it's just a bedside investigation that's available with you?
As a bedside investigation, as it is available, I want to do USG sir. With that, I want to order urine analysis and complete blood picture and renal function test for this patient, sir.
Yes. Yes. You have done ultrasonography, you have ordered, and are you allowed to do the ultrasonography yourself in your department?
Yes, sir. We are allowed to.
Normally, I have seen you do ultrasonography. So ultrasonography is done.
Yes, sir.
Yes,
Is
sir.
it there?
Yes, sir.
Ultrasound? Show the ultrasound. So what you are finding in the ultrasound?
Salman sir, which is right or left side?
Sir, the
The
video
video
which
showing.
is right side, sir. The static image is left kidney, sir, and the bladder. Only 3 cuts are there, sir.
Okay.
But Salman, the pain is on the left side, is
Pain
it?
is on the left side.
Yes, sir. Pain is on the left side, sir, but left kidney is
Ah,
normal appears on ultrasound, sir.
fine, fine.
Left
Okay.
kidney appears normal in shape, contour with normal CMD, sir, corticomedullary differentiation with no evidence of any PCA separation on the left side, sir. On the right side, that image shows hyperechoic shadow present in the near the renal pelvis and near lower calyx with a post-acoustic shadowing present, sir. There is no evidence of any
Why there is corticomedullary differentiation?
uh, because of the differential blood supply, sir.
What
Yeah.
differential blood supply? When cortex also receives blood, medial also receives the blood.
Also blood. So why there is hyperechogenicity in the medullary portion?
Because of that central echogenic complex which contains vessels with fats which appears as hyperechoic, sir.
There is a blood vessels which passes along the pyramids, right?
Wow, yes, sir.
That becomes an arcuate artery and supplies the cortex.
Yes.
Yes, sir.
That is why you see
Arcuate artery, then
hyperechogenicity.
interglobular artery.
Yes, exactly. And there is one more area which is hyperechogenic in kidney. More hyperechogenic.
Renal pyramids, sir.
Hilum.
Hilum.
Yes, because it is again all blood vessels enter through that. Hilum will be hyperechogenic.
Yes, sir.
Okay.
So are you little confused with this ultrasound report, or you are happy with the ultrasound report?
The patient is having left side predominant symptoms, sir. But the
Yeah.
ultrasound shows there is no evidence of H1 on the left side, but there is a hyperechoic shadow present in the right lower pole, right side kidney lower pole, sir.
Yeah.
So asymptomatic right renal cavity, sir. With there is no
So
bladder appears normal, sir.
okay. So with this ultrasonic picture, what has come to your mind now?
There may be we are suspecting one of the differential diagnoses as stone disease, sir. So
Stone
sometimes the
is
patient is
present in the right side. For
rheumatoid
the
arthritis patient, sir.
left renal pain, what are you thinking now?
Patient is a known case of rheumatoid arthritis, sir. There will be possibility of papillary necrosis, which might be the cause of pain on the left side, sir.
Papillary necrosis with rheumatoid arthritis.
It may be
Is
passed
it very common?
rare, sir.
Dr. Sir, have you ever encountered this kind of a relationship? I have not.
Yes, sir.
Diabetes,
Anyway,
yes.
anyway, it's a confusing ultrasonographic finding to you. For the examination, it is definitely confusing. So you have got the blood report. Creatinine is 1.32 and urea is creatinine is 1.1.
Yes, sir.
Okay, you go to the blood report. He
Blood
has advised.
reports.
So a blood report is quite acceptable. How will you solve your riddle?
Now
What
the
will you do
creat is
now?
1.1, sir. The creatinine is 1.1 with blood parameters and all normal. You want to do CT-KV for this patient, sir. Contrast enhanced CT-KV for this patient, sir. With this available report.
I think before you move forward, I think Murugesan Ranjan sir asked you what could be the reason for the left loin pain.
Uh,
You said papillary necrosis producing obstruction and less likely to accept for an examiner
yes,
because
sir.
there is no idonecrosis there. No stretching
Maybe
there.
passed out
Say
calculus
common,
might be
you'll
there, sir,
have to
which is
say
not.
common thing.
Yes, sir.
Isn't it? You'll have to say common thing. Anyway, tell me. I accept. I always accept. So you tell me what is the urine report, present urine report? Is it there?
urine routine and the urine.
Urine routine, good. Pus cells occasional, so you can rule out infection.
Yes, sir. The urine
So-
culture no growth, sir. Pus cells occasional, sir.
Okay. So your next step, you want to do a CT urography.
Yes, sir.
CT urography. Okay. Show the CT urography report. Because clinically there is tenderness in the left side, isn't it?
Yes, sir.
She said there was tenderness in the left side.
Pain only, sir. There is no tenderness. Only pain is
Non-tender. It was non-tender.
Yes, sir.
Okay. Then what is your CT finding? Before doing CT, you read the CT scan, you tell me what are the things you are looking for in CT.
patient is having
First, how
this
you read the CT?
plain CT KUB, sir.
NCCT QV, non-contrast CT.
Non-contrast CT KUB showing left kidney is normal in shape, normal in size with no evidence of PCS dilatation. There is no evidence of any perinephric collection or perinephric fat standing. Right side, hyperdense lesion present in the right renal pelvis, also occupying the lower calyx. There is no evidence of HUN is there, no evidence of hydronephrosis.
Why you want contrast CT? Why can't you take plain CT?
In ultrasound, there is a lower pole calyx there, sir, which is around approximately more than 1.5 centimeter. So, for if you are planning for any intervention, then we have to do contrast enhancer CT, sir.
What is
No,
the
I think
problem with the
question is-
contrast
yeah.
CT?
Question is pretty specific. Why you wanted an NCCT, not a contrast CT in this case?
What are the disadvantages of contrast CT over the non-contrast CT? What is the gold standard for a stone disease?
If we are NCCT KUB is the gold standard, sir. But if you are planning for any intervention, then we have to do contrast enhancer CT.
What is low dose CT?
Low dose CT, we have to, if it is less than 3 millisievert, it is low dose CT, sir.
Good.
These are specific questions, Murugesh, will come to your examination. A normal CT, it's around 10 millisievert.
Around
Low dose
10
CT
millisievert, sir.
1 to 4. Ultra low dose is less than 1.
That's
Chances
one.
of picking up a stone in a normal CT, NCCT is 97%. Low dose CT is 90%. Ultra low dose CT is 70%. There are specific questions which will come on your exam.
The
Now,
common question.
Yeah, please.
But you have some logic of advising CCT in this patient. Can you tell me what? Can you tell me that your decision is right? I'm supporting your decision, but why? You will have to explain why you are right.
I want to know the functional status also, sir, for this patient. For medical legal purpose also, I want to do, prior to intervention, I want to do contrast CT for this patient.
NCCT is gold standard for stone disease.
Yes, sir.
You have got in ultrasound the evidence of stone in the right kidney, but not in the left. So
Yes,
there may be some other associated pathology. There is not even any hydronephrosis or a hydroureter also in the left side in ultrasonography. So in that case, whether there is any other pathology related apart from the stone is best appreciated in the CCT. Do you understand?
Yes, sir. Yes, sir. Retroperitoneal fibrosis.
The chances of retroperitoneal fibrosis to present as hematuria is very rare.
That a dilatation.
It usually
There will be
present as
dilatation pain. Dilatation.
That will be
There is
dilatation.
no such thing. So, what else? Very interesting case. Thank you.
Welcome, sir. Welcome, sir.
Our discussion is a very interesting case. Tell me, next CCT finding is what?
Sir, the remaining cuts of CT plane, sir, lower cuts of CT plane.
Yeah.
Any more CCT place? Yeah.
Sir, there is one small cal in the left distal ureter, sir,
Yes. So
which
what
might be
does
the
that
cause
prove?
of
Yes, there is one website. So then what does that prove? In case of acute abdomen, when he was thinking of urinary pathology, the diagnosis of choice is NCCT-QB because ultrasound is a operator dependent. Number two, the patient is unprepared. In that
yes,
case, you may not get the right picture in ultrasonography.
ultrasound case.
Yeah.
Ranjan sir, what will be your take on an X-ray KAB when these candidates suspect a stone disease?
No, I will definitely advise on the academic background, especially in a medical college, if it comes, it is always better to go for NCCT QB. Unprepared QB, X-ray QB has got very little clinical findings. Most of the time, guards are dilated, guards overshadowed. Unless the patient is prepared, X-ray QB has a very little role in the present day scenario to get the diagnosis. That's because I am very happy that ultrasound missed this stone and there is no back pressure change also seen, and that proves why the NCCT QB is so very important in clinical practice. Okay.
Yes, as Ranjan sir correctly said, in an acute pain setup, you may not even have an hydroureter nephrosis for the first 2 to 3 days. Patient will
Yes.
have unclear full obstruction. In fact, Ranjan sir, in nowadays, we know that when you do an IVU, there may be even a non-visualized kidney also
Yeah,
removed.
non-visualized kidney.
Yes.
Non-visualized kidney. So NCCT QB is your investigation of choice. But
Yes,
here you have done the CCT that will show you everything.
yes, sir.
And
Yeah, Murugesan, as I think the examiners are saying, the NCCT-KB is the investigation of choice to find out the diagnosis. Now, once the diagnosis comes, then you can go for a contrast CT when you plan your intervention. So, when the examiner is asking what is the gold standard for diagnosis, the NCCT, but this particular case, since
NCCT
it is a
KABs.
confusing scenario, your contrast CT is well accepted by Ranjan sir.
Now, because ultrasound could not pick up any definite pathology on the left side and patient presented with pain in the left side. So we'll have to find out other causes. So with this, what else you want to do? What else do you want to know?
Um, I want to know the size of the stone, sir, and the location of the stone on the right side, as well as details regarding the stone morphology, as well as left.
So what is your plan?
anything else you want to know? Anything else you want to know in the CT?
Um, whether there is normal contrast uptake is there or not, there is.
What about HU? Is it important?
Yes, sir. It is. Yes, it is important, sir.
Units are important.
Yes,
Is
sir.
there any way to find out whether it is an uric acid stone, non-uric acid stone in CT?
Yes, sir.
Apart from HU. Apart
We
from
can do
HU.
dual energy CT, sir.
Dual energy. Yes.
Yes, really
We
electricity.
can know the composition of the stones based upon it.
You can say only differentiate uric acid and non-uric acid stone. That's all. You
Yes,
can't
sir.
say
Yes, sir.
specifically whether it is a this and that. It is not
Yes.
possible. Yes.
Yes, sir.
So what is the protocol to do a dual energy CT?
Sir, we have to use two different energy sources, sir.
Exactly. You do a complete dual energy CT or you do a specific to the stone only. Yeah, ideally, what you do is you do a low dose CT, and in the stone area you do a dual energy CT. So your area of interest to know about the stone composition. That's all.
Yes. Okay.
What is ALADA?
It is as slow as reasonably achievable, sir. We have
Uh-huh.
to as slow as reasonably achievable, sir. We have to do low dose CT for the patients in order to prevent radiation hazard, sir.
Yes. Yes. So with this report in present to you, how will you talk to the patient and the patient party? How will you communicate with the patient party? Patient.
One question.
Yes, yes,
Yes,
yes.
sir. Now the investigation is over, so all four of you can join, sir. Two
Sir,
candidates and two examiners.
he
Yes.
has mentioned stag on calculus. Are you happy with that?
Sir, they didn't mention about whether the stone is occupying the pelvis, but in the CT, there is a stone occupying the pelvis with one my lower calyx it involved, sir. So it is partial stagnancy.
Partial. What is the definition of partial stag on?
The stone occupying the pelvis with more than one calyx, sir, more than one major calyx.
More than one calyx. Then what is complete stag on?
Yeah.
If at least more than 80% of the calyces are involved by stone, it is complete stagnancy.
Yeah, it's
Complete
less than
stag.
2. Partial is less than 2 with the
Yes,
pelvis.
sir. Yes, sir.
So what will you do next?
The patient is having left loin pain, sir, with 8 mm calculus, distal ureter, with a 2.5 centimeter right lower pole calculus, sir. The HU of around 1200. I want to do urine culture. I want to do PTIN or
Urine culture
bioablation profile
done.
for this patient.
Urine culture done, no growth.
Yes, sir. No growth is there with the PTINR and all normal. So
You
I
just
want to
tell us
do
the options you have to treat this patient. Just the options.
left side URSL with right side PCNL for this patient.
Left side URSL, right side PCNL. Is there any role of medical expulsion therapy in this patient? For the left
Yes,
side?
sir. Yes, sir. Left side, the stone size less than 10 mm, distal ureter. It is favorable for medical expulsive therapy, sir.
You just tell me what is the principle of medical expulsion therapy?
You have to give alpha blocker, which will relaxes the smooth muscle of the distal ureter and VUJ, sir, which will thus it facilitate stone spontaneous stone passage, sir.
With a 8 millimeter stone, what is the percentage of successful medical expulsion therapy?
It is if it is more than 5 mm, usually it is around 50% in distal ureter, sir.
If it is more than 5 mm, isn't it?
If it is more than 10 mm, now there will be less chances of passing. Then we have to intervene.
So, medical expulsion therapy has a role in this patient, especially why? Why it is so important in this case? Tell me. Female patient.
Patient's creatinine is normal, so
Yes.
there is no
Yes.
obstruction. Patient is not in an obstruction.
Yes. There is no infection, there is no obstruction. Patient should be given a trial of at least 7 to 10 days for the medical expulsion therapy. If she cannot pass, then you can think of doing a surgical intervention. And that case, what is your option? What is your option?
I'll discuss with
Left
the
URSL for
patient,
this patient with the right side PCNL for this.
Right, so you want to do both the sides simultaneously or separately?
The patient is asymptomatic on the right side, sir, with the symptoms only on the left side.
Yes. What will you do
So better to prefer left URSL first, then we can plan PCNL on the later.
then? On the other side, you want to do PCNL. Hey, sorry, URSL. What problem you can face while doing URS in this patient?
sir, it's a distal stone, so there's a and it has not. If it has not come out by now, so we expect that there could be some narrowing in the distal ureter, or VUJ could be edematous. So it
What is the narrowest? What is the narrowest part of the ureter? Which is the narrowest part?
VUJ, sir.
VUJ. So it's
Right,
obviously we
VUJ.
expect the stone to get
Get
stuck there.
there.
So it is also a difficult point to enter also, because that is the narrowest part of the ureter. There may be different types of ureteric orifice. So what are the types of ureteric orifice and which gives you the most trouble for entering into the ureter? You never know, only after doing a cystoscopy you can find this problem. Have you ever
Sir,
seen
now
difficult
cone,
entry?
cone shaped, stadium shaped, then golf ball orifices. Another one is horseshoe shaped orifices, types of orifices.
Yeah. So which gives you trouble?
That cone shaped, it will be difficult to enter the orifice. As
Cone
well as
shape.
golf ball usually associated with JUTB, that will be difficult to enter.
Waterfall is not the point. Cone shaped, looking at the opposite side. You know,
Yes, sir.
cone shaped ureteric orifice looking at the opposite side like this.
Yes,
You
sir.
are going from here. Very difficult to
Yes, sir.
communicate. How you can overcome the crisis? Have you seen this kind of problem in 3 years? Must be in at least two, three cases. You must have seen the entry problem in entry into the ureter. You must have seen.
Yes, sir. Yes, sir. We saw, sir. Professor guided us, sir.
Huh?
We saw,
Safely
sir.
bring Professor to trouble. Professor guided us, yes.
I'll give you one scenario. I'll give you one scenario. Same stone. Okay, you are able to pass a guide wire 1 centimeter. Beyond that, guide wire is not going. So you are not able to enter the ureteric orifice. Stone is just 1 centimeter above. So how will you manage that situation?
There's no
Sir,
guide wire is also not going.
Guide wire is not going. You are not able to enter also. Stone is not seen. If stone is seen popping out, it is you can do a myototomy and come out. Fair enough. It's an easy
yes, sir.
job. How will you tackle that?
Ureteric entry problem is a serious problem for the ureteroscopy. How you have to overcome this problem?
1 centimeter. Your guide wire is going 1 centimeter. After that, it is not going. Is there any way?
I'll use a smaller scope. So if I'm using 6, I'll use the 4.
Guide wire is not going. So do you expect a smaller scope to
No,
get it?
no.
What will you do then?
Guide. So antigrade can I try antigrade?
Retrograde, anything you can do?
Up to VUJ.
We can do
Antigrade up
balloon
to VUJ.
dilatation
Okay.
for the.
You say I accept antigrade up to VUJ. You tell me where will you make the puncture?
The system is not dilated. This is not an ideal case for antigrade.
So what will you do?
You can use hook.
Can use it, sir.
So what is usually you can do is you can see the orifice. You pass the hook and cut that part. So then you can. It becomes easier. You can see the stone and break it. That is one way of doing it.
You know, there are different types of ureteric catheter. Have you seen right angle ureteric catheter?
Yes, sir.
Have you
The
seen?
J-tipped.
J-tipped, right? Different types of ureteric catheters are there. With the help of guide wire, you have to try to manipulate very carefully without traumatizing the ureteric orifice. Once you traumatize the ureteric orifice, you will have to abandon this way. And that case, you will have to think of other options. So always read and remember the difficulties you can encounter while entering the ureter and how to solve it. Possibly Dr. Savni's one took a session where he explained, I don't remember in full stretch to tell you the direct steps. Is it in Dr. Savni's book? I will find out.
I don't think so, sir. It's not in the book.
So. It's not in the book. He once taught us in the Madras only, in the Madras Medical College before COVID. There was a USI mock class
Yes, 2020 Stanley we had on mark.
22 Stanley. Yes, that yeah, I was there. He was only telling. Anyway, different types of angled ureteric catheter to reach the ureteric orifice in the right dimension and gradually using. If you have cardiac guide wire, where the coronary stents, the way the coronary stenting is done, you can use that cardiac this thing guide wire, terumo guide wire, to overcome the obstruction and gradually dilate the thing to enter it. Otherwise, it's very difficult in that case. And I remember in my lifetime, I had to at least 3-4 times I had to go for open ureteral lithotomy because I could not enter.
And I think both Prashant sir and Ranjan sir,
Yeah.
in our days, we use the 3 French ureteric catheters to go inside. Nowadays,
Yeah.
all these postgraduates are trained only with guide wires. 3 French ureteric catheter nicely goes in without troubling
Yeah.
this thing.
Yeah.
It doesn't go into false patches. These guide wires
Yes.
can go into false passage when they push. And
Ureteric catheter is of great help. Great
somebody
help.
was saying balloon dilatation. Balloon dilatation is not possible
How
because it's
can
going
you,
one side.
unless you have access, how can you do dilatation? You'll have to have the access first. Then only you can go for dilatation. Okay, time is going. You tell me, suppose you have entered. What energy source do you prefer for ureter?
In lower ureter, we are pneumatic lithoplasty.
What are the other options?
You can use electrohydraulic. For proximal ureter and all, we can use.
No, I'm telling you distal ureter. Distal ureter only. What are the options of energy to break the stone?
Ultrasonic, sir. We can use ultrasonic also.
Madam, what are the other options?
If there
Sir
is
is not
adequate.
asking whether you use it. What are the other options you have?
Oh, we can basket it, sir. If it's
You can use laser also, sir.
distal ureter, we don't want to use the laser so much.
So your preference is pneumatic lithotripter,
Yes, sir.
isn't it? What is the problem with pneumatic lithotripter? I know you don't want to use holmium laser because the chance of stricture later on is there. So you
Yes,
tell
sir.
me what are the problems of pneumatic lithotripter? What you prefer?
Stone will retropulse. That is an issue with pneumatic lithotripsy.
Next.
If it is a hard stone, it is difficult to break also.
Yes. Third, most treacherous and dangerous.
It will possibility of going into the mucosa is there, sir.
Yes, mucosal injury, which is very important complication. How do you avoid this complication? I'm asking very practical question to you because that will be asked for your examination. Theory all are read and written in your text. You tell me how can you avoid mucosal injury while you are doing this lithotripsy?
We can use
hit in the center of the stone, sir, first.
You are right. But before that, step by step vision should be always clear. Number one, your scope should be in the straight line, not any oblique vision of the stone should be attempted with lithotripter. Number three, the energy you are using, there are different modules, I mean, by which you can control the force you are putting on the stone, isn't it? So you must keep the lower energy for the lithotripter while you are breaking the lower ureteric stone, because there is an obliquity in the ureter. Unless you make it straight line, you may not break the stone completely. Okay. And what is the fourth problem?
We can't dust the stone, sir. We can only fragment it.
You only fragment, and insertion of some kind of a stent after the surgery is mandatory. Number 5, it can go up even the lower ureteric stone with a single stroke of a lithotripter can fly back into the PCS. All we have seen in our life. Okay, so that is the limitations of this procedure. So what energies, which machine do you use in your system, in your hospital?
Pneumatic lithotripsy only, sir.
Well, which company?
It's
I'm
Swiss
asking.
lithoclast, sir. Swiss
Huh?
lithoclast. We have
Swiss
Swiss lithoclast.
lithoclast. Swiss lithoclast. What is the advantage of the Swiss lithoclast over the local lithoclast?
Yes, both the ultrasound as well as pneumatic, sir.
No.
I'm just asking you about the pneumatic only.
See, that is
I'm
a newer
asking-
modality. You are talking about triology.
Yeah.
Lithoclast mask.
Triology, these are very expensive thing. You know the price, 15, 16 lakhs rupees for this lithotripter. You tell me normal pneumatic lithoclast you use. What did I ask you? You have forgotten.
Swiss
What question I have asked you?
Swiss lithoclast.
So what is the Swiss lithoclast? What is the difference with the common Indian lithoclast?
How
Do
it
you know?
works, actually?
It conducts better, sir.
Which
Breaks
conducts
better.
better?
Swiss
No, I'm
lithoclast.
telling you, Swiss lithoclast have a only one directional movement. This Indian lithoclast has a bidirectional movement. It actually moves like this, goes up, front and back, also from side to side. That is why you will see the ureteroscopes are damaged more frequently with Indian lithoclast, because there is trauma to the triplets. There is trauma to the triplets, and that is the advantage of the Swiss lithoclast over the Indian lithoclast.
What is the principle of pneumatic lithoclast? Principle?
Yeah.
What is the principle?
तुम्हें very जल्द दरकार है.
Compressed.
Yes, sir.
What is the principle of Indian
The compressed.
lithoclast?
That is, you can use oxygen also. You can connect to the central oxygen. You can break the stone. Air, compressed air also you can use it. It's just a conversion. What is the exact principle? It is also called ballistic.
Jackhammer effect, sir.
So exactly, if you
By
open
means
the hand probe, no, you see one small bullet there. You have seen that
Yes, sir.
bullet?
Yes, sir. Yes, sir.
So it's an energy transmitted. That bullet moves and that energy is transmitted to the probe. And that is how this thing. Why electrohydraulic is not used? You told electrohydraulic lithotripter is one of the modalities. Why it is not used nowadays? I have not seen. I don't know about sir. Sir has seen electrohydraulic.
We have not seen for this ureteroscopic stone breaking, but
Yeah.
of course for the lithotripsy we have seen electrohydraulic, then
And electromagnetic.
piezoelectric, all we have seen.
Shock
No,
everything.
I'm talking about piezoelectric also.
Here it was used before URSL.
Yeah.
Electrohydraulic is used.
Yeah,
Now it is
yeah.
not used. Why?
No, it's not.
It is there.
That's the answer. It's a very simple answer, but
It is in Campbell. It's a heavy handle. The handle is very heavy and the probe size are bigger. Okay, the retropulsion is more. So that is why it is not used. So that is why pneumatic has become the new norm.
he has asked you what is the principle of the pneumatic. Can you tell me what is the principle?
I only told, sir.
Ballistics are just told, sir.
He was just uttering the word without knowing the meaning. Then it is actually pinpointing the energy. The bullet is quite large surface area. The base of the probe has a larger surface area, but it is transmitted to a small point at the tip. So the concentration of the power which is being delivered at the bottom is multiplied at the tip. You understand?
Yes, sir.
So you have tried, it's a very hard stone. You cannot break it completely and you have injured the ureter. How much time left?
Sir, we can go ahead, sir.
Yeah.
Actually, at 8:30, we take the questions. Since not much of questions today, I think we
Yeah.
can go ahead with the discussion, sir.
Yeah.
There are only one or two questions that have come up so far.
Okay. So you tell me what are the other options?
For the right or the left, sir?
No, I'm talking about the ureteric stone only. Right is a different story. Patient has come with the left and side pain. Laser. So what precaution do you take in laser? About the stone is not breaking. What precaution you will take for laser?
Avoid mucosal contact, sir. You have
Only
to
that.
keep it.
Only that.
We should keep it in the dilated part of the ureter. We have to keep the stone and avoid mucosal contact. We have to.
Anything else?
So make sure irrigation is always on flow, sir.
That is applicable for any ureteric stone disintegration.
Yes.
For laser, to protect the ureter, what is the basic? What is the basis of protection? What will you do?
Irrigation.
Madam, you will have to keep the energy low.
Energy low.
You will have to, this is the very simple thing that you will have to keep the energy low, not more than 6. What is, how do you calculate laser power? Its frequency and have you used laser?
Joule, sir.
Have you used laser?
Yes, sir.
The frequency and joule. So ureteric stone should not go beyond 6. Then only the protection to the ureter takes place. And at the same time, you cannot make a continuous buzz. When you touch it, don't put your foot directly on the foot piece and let it go. Never do this. Always break the stone in buzz. 1 or 2 buzz, wet. 1 or 2 buzz, wet. Allow the water to flow. There should not be much rise of temperature at the site of the stone disintegration. And don't be impatient for breaking the stone. Don't be impatient. Keep your hand steady. Break the stone at the middle with interrupted buzz and low energy. Okay? You have done all these things.
What is the ideal size of laser fiber you use for with the 6 French ureteroscope? Ideal.
I don't know, recommended. We use
We can use
270.
200 microns. Sir.
200 micron is ideal for RIRs.
RIRs.
For the ureteroscope, what will you use? What are the normal laser width? For prostate, what do you use? For ureteroscopy, what do you use? And for RIRs, what do you use? You must read all this. Okay, these are the practical questions. You must just tell me you have done a fantastic stone clearance quickly. You went in and came out. Okay, after 3 months, patient came with little bit of discomfort in a lower abdomen and there is pain also. What has come to your mind or how will you proceed to treat this patient?
So 3
We have
months
to do.
later, when I've already removed the stent.
No, you have put the actually broken the stone and put a stent because a laser or lithotripsy normally lower ureteric stone you always take it out. You don't keep a piece of stone in the lower ureter. Okay, after removal of the 3 months after that, patient has come with pain. How will you evaluate the patient? What will you do first?
First, I will do ultrasound to look for any HUN is there.
First, you should do one urine culture, rule out infection. Okay?
Yes, sir.
Don't jump, just don't jump.
Yes,
Then
sir. Yes, sir.
you will do
Ultrasound to look for any hydroureteronephrosis for this.
yes, hydrourethral nephrosis. And you see there is some more than minimal dilatation of the left ureter, more than minimal dilatation. Some amount of dilatation may exist because of the pre-existing. There is more than examination. How you proceed with this?
You will check for the you will check the renal function test for this patient, sir. If it is normal,
Okay.
then the patient is having significant hydroureteronephrosis on the left side. Post procedure, I want to do.
How will you break the situation to the patient? Because you have operated on her, you have only operated on her.
Yes, sir.
So you will have to say how you break the news or how will you convince the patient. You will be a clinician after 6 months. So you will have to face it. What will you say to the patient and the patient party that this has happened? What? How will you do that?
There will be chances of one of the complication of doing URSL using laser and all. There is chances of stricture is there. We have to explain and we have to.
Yes, before the first surgery. Before the first surgery, you will have to explain that this procedure has these limitations.
Yes,
No, that you must inform in writing. That this may be one of the complications which can arise of. Okay, once you have done it, how will you confirm it?
then I want to do CT urogram with a delayed film, sir.
Okay. CT urogram is showing a short segment ureteric, lower ureteric stricture on the left side. How will you manage it?
Sir, I want to also know the functional status, sir. DTPA for this
Yes,
patient.
yes. So we'll have to do a DTPA.
Then
You have done CCT. CCT, if it is showing normal expression, then you can avoid DTPA. Then what will you do? How will you manage this patient?
uh, after short segment, there is a less than
Lower
2
ureteric
centimeters.
stricture. 1.2
Yes, sir.
centimeter length of stricture, which is 4 centimeter, 3.5 centimeter above the left VUJ. How will you manage this stricture?
Ranjan sir, if you can just allow me
Yes,
one
sir.
small comment, because there are 104 students attending this program. This is a very
Okay.
important point actually Ranjan sir is making, because in your practice you will see these patients, especially URS done by another surgeon, and the patient will come to you with an ureteric stricture. You should be there good enough to tell the patient that this is a complication, can happen to anybody. This is not because of the procedure. This is very important. We have seen a lot of patients like that. And yeah, please sir, go ahead. How do you want to manage?
And never, to complete his statement, never criticize your colleague.
Correct.
Never criticize your colleague, be in government, be in private. You are in government, you will criticize your private part, and the private people will criticize your. So never do it on principle. Anyway, how will you manage it? You tell me.
It is a short segment stricture of length 1.2 centimeters, sir. So there is a renal function is adequate. Then we can try for some stenting for this patient, sir. By doing
Do you
RGP, then
think?
I want to do stenting, sir.
Do you think stenting will allow the stricture part to get dilated permanently?
No, sir, no. But I want to
Buy
do
some time. You can simply buy some time. So, what is the final management of this patient?
I want to do ureteric reimplantation for this patient, sir.
Reimplantation. How will you do ureteric reimplantation, madam? How will you do ureteric reimplantation?
So it's a short segment, so I can even do end-to-end for this patient, sir.
Lower ureter end-to-end, and you are saying reimplantation.
Lower ureter is better to reimplant, sir.
So, how will you do this reimplantation? Or what are the types of reimplantation? First, to tell me in short.
So we have types of reimplantations can be reflux and anti-reflux, sir.
Yeah.
So we have Cohen's reimplantation and
Cohen.
Modified Lish-Krieger
modified
technique we are doing,
Lish-Krieger
sir.
reimplantation. Yes, sir.
I'm just, your center is famous. I mean, the Madras Medical College and others is famous for the renal transplantation. Normally, what kind of ureteric reimplantation is done there?
In our institute, we are doing refluxing type of ureteric reimplantation, sir, for renal transplant.
What is that procedure? What is that name?
It's
You have said it once.
Lish-Krieger only, sir.
Modified
Yes, sir.
Lish-Krieger.
Yes, sir.
So in this case, what will you do? Because she's 60 years old lady.
A 60 years old lady, sir. Already the renal function, units are stabilized, sir. So I want to do refluxing type of anastomosis for this patient, sir. By doing.
How will you do it? What will be your approach? Open or laparoscopy?
Yes, sir. Open or laparoscopy we can do, sir. By open approach, we by putting Gibson incision after. Then we have to dissect it as slow as possible. Then we have to disconnect it. Then after filling the bladder, we have to put incision over the bladder. Then we have to do.
After putting incision over the bladder, before putting incision over the bladder, what step do you take?
I want to do stay bites, sir.
Stay
sutures.
To make the bladder full.
Yes, sir. Make the bladder full and
make the bladder full, preferably some air to be injected inside the bladder. For what?
Yes, sir.
To make a air-filled surface for better stretching of the bladder wall.
Yes,
okay, and you can see it when you give the incision on the detrusor. You can see the peeping up bladder mucosa.
Mucosal
you can see. You can. Anyways, you are not a surgical this thing. So be sure. Never criticize. Always explain to the patient before surgery that these are the standard complications which can take place to anybody on earth. Number 3, that this is the to do this to prevent this, we will take these precautions, and in spite of that, if such thing takes place, this is the management protocol. Okay.
One of the dreaded complication is ureteric avulsion. Okay. Yeah. No surgeon wants to have that. How will you intraoperatively identify that ureteric avulsion is happening?
There will be telescoping of the ureter within the.
More than we will lose the vision. We will lose the vision, sir.
So when you are withdrawing the ureteroscope, ideally ureter should move away from
vision, sir.
Yeah. If it is coming nearer to you, whatever the ureter you are coming out, that means you are avulsing the ureter. Okay.
Prashant, in this case, the URS was done. Luckily, they were able to clear the stone comfortably on the left side. Now, what to do for the right side is the bigger question. Now, patient is asymptomatic. So, yeah, we'll take Murugesan first. Patient asymptomatic, what do you want to do on the right side?
Right side.
Yeah.
Yes, sir.
Have a 2 centimeter calculus on the right
lower
side.
pole, 2 centimeter calculus.
Not lower pole. I think it's pelvis and partly going to the lower pole.
Lower pole, yes.
Yes, sir. Yes, sir. I want to do PCNL for this patient, sir.
Patient is asymptomatic, 60 years. There is the next question Prashant would like to ask you.
Want to treat this patient, 60-year-old female?
Yes, we can observe also, sir.
What is the problem of observing a patient with the pelvic calculus like this? Prashant, I'm just mouthing for you. You don't mind. What is the problem of observing this patient? Patient is
There will
asymptomatic.
be, yes, sir. There will be harboring in the stone will harbor the infection, sir.
So what
So
will
some
happen?
complications.
For example, if you observe the stag-on calculus, what will happen? See, there are stag-ons. Most of the time, it will be asymptomatic. You just don't want to
Yes,
observe
sir.
that thing. Why?
There is progressive deterioration of renal function because of obstruction. So patients,
What is the percentage of the patients will go for a CKD in a stag-on calculus?
15% of patients.
15 to 30%, around 30-35% will go for a CKD. That is the one thing. And recurrent infections. That is another one. And it's a pelvic stone. Sir has told pelvic stone. So it can cause obstruction.
So if you wait for 8 years, there is a 14% chance that the patient can go for a CKD. If you wait for 17 years, there is a 50% chance you can go for a CKD. For that, you have to know what is the life expectancy of this patient. How do you calculate the life expectancy of these patients? So you should read about Charlson's index. So if the life expectancy of this patient is more than 10 years, you better treat this patient. Even though the patient is correct depression, you better
Yes,
treat
sir.
this
Yes, sir.
patient.
I
Even though
agree.
these patients are asymptomatic, you better treat these patients. So if you want to treat this patient, patient says, I don't want a treatment. I'm completely asymptomatic. I don't want a treatment for this. Then what will you do? You have convinced yourself there is a candidate for surgery, but she says, I don't want surgery. So what will you manage this patient? Afsar.
She
Okay,
is
thank you
not
very much.
willing for
Okay.
surgery.
Or you want to keep the patient on follow-up. The question is, how do you follow up this patient? If the patient says, I don't want surgery, how do you want to follow up this patient?
Sir, I will 3 monthly. I will do a repeat ultrasound to see if she's going into obstruction or there is progression of if creatinine is increasing. I just keep her on a follow-up, sir. Repeat
You want to see the stone
cultures
is
and
increasing in
ultrasound.
size, that is fair enough. Anything else? You are worried about something else. You're worried
We
about
have to
developing infections.
NFA.
You're
look
worried
for
about
serum
renal
creatinine, sir.
function deterioration. So you have to do a renal functional study in these patients and see where the function is deteriorating, and you have to do a culture and see whether the culture is staying positive or the patient is developing urinary tract infection. Then you can convince this patient for a procedure in this particular stage. Yeah, please go ahead. Prashant, please go ahead. Once we complete this case, we'll take some questions. There are a few
Yes.
questions that will come up.
It's a mainly inferior calyx and with the pelvic stone.
Yes,
So
sir.
which calyx do you prefer to puncture?
For this patient in supine, we can plan for lower calyceal puncture. We can remove most of the stone burden, sir.
Okay. What is the advantage of a prone PCNL over supine PCNL and supine PCNL over prone PCNL?
In in prone PCNL, we can have better vision, sir, as well as
Vision
there
is
will be
nothing to
better.
do with this thing.
There will be better
It is
irrigation.
depends on the scope, right?
Yes, sir. Yes, sir. That will be good irrigation will be there, sir. So there will be better vision for that in prone patients. In supine,
See, the prone this thing, stone fragments will come automatically because of the
in
Gravity.
supine, in
okay.
supine.
There's no need to pick all the fragments and all. Just with the pressure, it will come out. That is the
With
one
the
thing.
whirlpool effect, it will come out, sir, on its own
Yeah.
in supine. Yes.
Yes. Advantage of supine.
There will be less chances of we can use that in patients with high cardiac risk patient and all. We can put the patient. There is no need to change the patient. Put the patient on any
Okay.
positions.
Then any advantage the most important why supine PCNL has come into the this thing picture.
Time savings, anesthesia wise, the patient does not require.
More than that.
Hello.
You can do it.
Low
PCR,
pressure. Low
Simultaneously.
pressure. It will
In
be
a
low
single
pressure,
puncture,
sir.
you can't clear all the stones sometimes in a prone PCNL. You might have to do a multiple punctures. Here, there is always an advantage of going into the other
Doing
calyx and
endoscopy
clearing with the.
combined
Yes, exactly. That is the advantage. Okay.
ECRIRS we can we can do, sir.
Exactly. Right. Okay.
Yeah. So Prashant, your take on this case is concentrate on the left kidney first because that is a symptomatic kidney. And
Yes.
once the left kidney is done, the question is whether you want to address the right kidney or not. Since this lady is only 60 years old and most likely might have a good predictive life index, it is better always to operate on the right side also, convince the patient for the right surgery. And the right surgery will preferably be a supine PCNL for you with an inferior calyceal puncture, where you can almost clear most of the stone burdens. Fine. During the procedure, Murugesan, if you have a doubt that you have not cleared the entire calculi, I think there are small calculi seen, multiple small calculi also seen there. If you have a doubt that you have not cleared the entire calculi, what are the options you have there?
Sir, we can put some flexiscope and then we can check, sir.
Okay, fine. Because this point is very important because most of the calculi are mixed calculi. You don't get a one full-fledged calcium oxalate stagon or a MAP stagon. Some of
Yes.
them have mixed density and some might miss. Once you break, they go into different calyces. You may not be able to pick it up in a CM. If you have an option of a flexi rhinoscope, I think you can do that also. That's also possible in this particular case. Prashant and Ranjan sir, can we take questions?
Yes,
There
sir.
are a few questions that have come up. I'll put the first question to Ranjan sir. Ranjan sir, all the while we were discussing the right side in this
Just a
patient,
minute.
in spite of the fact that the patient is asymptomatic, we'll still convince the patient for a PCNL on the right side. Your take on that,
Yes. There
Ranjan
are,
sir?
can you just repeat the
Yes, sir.
question?
Yes, sir. So
Yeah.
all this while we had a discussion, what do you want
Hmm.
to do for the right side? The patient is
Yeah.
asymptomatic. We came to a
Hmm.
conclusion that this patient is 60 years and the
Hmm.
patient has a good life index. There is a
Hmm.
chance that the patient can develop repeated urinary tract infections as well as
Yeah.
deterioration of renal function. So we'll
Hmm.
prefer to go ahead with the right PCNL and convince the
Yes.
patient for that. Your take
Yeah.
on this, sir?
Yeah, this is the right decision.
Because that's also one of the questions that has come up.
Yeah, this is the right decision because 60 years old lady in the present scenario not having much comorbidities, she has the expected life expectancy more than 8 to 10 years or 15 years from now. And if we allow this stone to stay in the kidney, it is not only the renal function deterioration, long-standing stone can also produce some changes in the mucosal character of the renal pelvis or renal pelvic calyceal system, and stone is one of the reason that can give, it's a long standing stone I'm talking about, can change to metaplastic change to squamous carcinoma also, now which has got a very bad prognosis, which and present day the risk of treating a renal stone with a dilated pelvic calyceal system and is very safe. So it is always better to go for removal of the stone at this age when she is having no other comorbidities, in spite of the fact the patient is asymptomatic.
Perfect, sir. That's the one other point which Sarah has added is long-standing stone can develop malignancy because of irritation and metaplasia. You may get a squamous metaplasia or adenomatous metaplasia there. So don't have to leave a stone because asymptomatic. You just don't have to leave a stone. One other question that has come up, I think, Prashant, you can take this question. This from one Dr. Swaroop. He has asked, what is micro CT? What is dual energy CT? Yeah.
Oh.
Micro CT, I think, is basically a non-destructive stone analysis. I think, Prashant, yeah, please go ahead.
Yeah, the dual energy CT it is only to identify the stones from uric acid to non-uric acid stones. Okay, it is what usually we'll do is we'll do a low energy CT, and along with that, when you detect a stone in that area, you do a dual energy CT. Use the two energies to find out whether it is an uric acid stone or a non-uric acid stone. So that is why always it is combined low energy, low dose CT with the dual energy CT is the ideal investigation. There are newer modalities also come like a photon counting CT, which is also helpful in detection of the composition of the stone. So these are the newer modalities.
And micro CT, you want to explain as is it an ex vivo or is it a vivo? It is ex vivo form of non-destructive stone analysis. It is not a CT proper actually. It's ex vivo form of non-destructive stone analysis because generally what we do is only a destructive stone analysis in the Fournier's type. This is a non-destructive analysis. That's the answer for the first question. And one more question has come. I think Prashant, once again, you can take it. Stagon calculus. What is stag on? What is partial stag on? What is complete stag on? Incomplete stag on?
The mainly thing is complete and partial stag on. Complete stag on is pelvis plus 80% of the pelvic calyceal system. It is a complete stag on. Partial stag on is a pelvis plus up to 2 calyces. Involvement is that. Then it is a partial stag on. And most of the stag ons are always struvite stones, and it can be apatite stones. Most of the time, these are the stones. Calcium oxalate having a stag on is very unlikely. And most of the time, it is a triple phosphate.
Triple phosphate. The most common stones are triple phosphate stones. The confusion here is always this stag on, partial stag on is a big confusion for us right from our UG days of reading. Stag on is it's the head of a stag. The stag usually has two horns. So when you say a stag on, at least two horns should be present. This is the basic. If it is one horn has fallen off, it becomes a partial stag on. If it occupies all the calyces or at least 80% of the calyces or three major calyces, then it becomes a complete stag on. So the reason of differentiating partial or complete is this thing only to know the punctures. Is one puncture is enough for you or multiple punctures enough for you? That is the main reason to differentiate partial or complete. Otherwise, the treatment component is going to be almost the same. Sir, Ranjan sir,
Yes.
people have asked why there is no HUN on the left side. Patient is
Why
having
there
pain,
is
why there was no HUN on the left side?
hydrurator?
Yes, no hydrotenephrosis on the left side. Why?
Because it is the early stage of the presentation. CT was taken. As soon as there is pain, for dilatation to take place, it takes some time for the system to dilate, and if it is stuck for a long time, then only there is systematic dilatation of the pelvic calycium and the hydrurator takes place. Because the CT was done almost immediately after the colic, when the stone moved from one place to another without getting the time to produce enough back pressure change to dilate it.
Prashant?
Yes.
Yeah, I think there could be three reasons for this. One, it is a partial obstruction. The second reason, as Saj told, it is a very early obstruction. If you read the previous editions of Pollock, 1990 and 2000, we know that it takes 48 hours for the dilatation to happen. Less than 48 hours, you may not see the dilatation. The third thing is sometimes it can go for an acute renal spasm of the blood vessels, where the flow comes down, automatically urine production also comes down. That is the reason for non-visualization of kidneys also in these cases. So in an acute colic, you may not have a dilatation. So this is a point to take for all our postgraduates here. There are 106 attendees now. In acute colic, you may not have a dilatation. So that is the reason why ultrasound may not be very useful in acute colic. You may have to go for a CT scan. Uh, Sir, Ranjan sir, in your experience, for an upper uterine calculi, which is very close to the pelvis, would you prefer a supine PCNL or a prone PCNL? Question asked by Dr. Vijay.
For
The
upper
skin is very
uretary
close,
calculus,
the upper ureter and partially jetting into the pelvis.
it is definitely prone PCNL. I do prone PCNL most frequently, though the incidence of PCNL has gone down in the recent past because of the RIRS and thulium fiber laser the laser thulium fiber laser. So if I do, I will definitely do prone PCNL because the angle from the puncture point to the upper ureter will be in the straight line. But in case of the supine PCNL, there will be obliquity to reach the ureteric area.
So you would prefer an upper calyceal
Oh,
puncture prone PCNL,
yeah,
will be more comfortable for you to reach the
yeah,
upper aortic calculus.
yeah, yeah.
Prashant, I think you have done more supine PCNLs
Sir, we
comparatively
do
at ECIRs.
prone PCNL is upper ureter. It is always safer to do a prone PCNL rather than the supine PCNL.
Good. So because the last case we had that was now outside practice, I had taken an inferior calyceal puncture. Luckily, I was able to clear the calculi, but we were worried whether I left any calculi at the ureter. We had to do an URS. Of course, since supine, we had the option to do an URS and see whether everything has been cleared or not. And the angle, as you said, because the angle is there, mucosal injuries are also common when you try to break the stone in an acute angle. The point which Ranjan sir was making, your scope has to be in direct angle when you break the stone.
Impedible pelvic angle is the one of the most difficult thing in even whether you take an RIRS or anything. If it becomes more acute, even the RARS with the inferior calyx stone becomes more difficult.
Difficult. Today only I could not reach one lower calcium stone with RIRS. I could see the stone with double reflection also. I could go very close to the stone, but I could not break it. So I had to go for a mini PCL.
Sir, you had preferred to take an upper calyceal puncture. This is a question again asked by one Dr. Rakesh.
Yeah.
If you get a pleural injury, then how will you manage that?
Pleural
So
injury, if you,
all these things are questions which are coming up to me, sir, not mine.
yeah.
Please. Yeah.
No, it's all right, all right.
Yeah.
Look, if you can diagnose the pleural injury at the time of the procedure, it is always safe to put a chest drain and allow the patient after recovery with spirometry, so that the this thing, your lung expansion takes place properly. But if you diagnose it later on, that case, preferably a single aspiration of the fluid from the pleural cavity and observation of the patient in most of the times solves the problem.
Prashant, now you have a full stack on calculate, more than 80% occupying. What puncture you would prefer? Dr. Vijay is asking what puncture you prefer. Single puncture, multiple punctures? If so, two punctures means which two calyces you prefer to take a puncture?
Ideally, it is all depends on better to clear the maximum burden in a single puncture. So whatever, if it is like a, for example, if the maximum burden is in the inferior calyx with the pelvis, first go ahead with the inferior calyx puncture and clear out the maximum burden. Then if it is required, you can put a IP needle, try to flush out the stone, bring it to the pelvis and try to break it. If it is still not possible, then you can do a mini perk on the corresponding calyces. That will be the better. It all
Perfect.
depends on the stone burden, sir. We decide the puncture based on the stone burden rather than just preemptively planning for a puncture. It becomes difficult. Sometimes the stone burden is more in the inferior calyx or upper calyx or pelvis. So depending on that, we can decide.
Good, sir. So you'll prefer to take either an upper calyx or lower calyx puncture based on the stone burden. And upper calyx from upper, you can approach the lower. From lower, you can approach the upper. Only the middle one is very
Middle
difficult
one
to
is
put another scope or anything. So you'll have to put one more puncture in the middle. So I think nowadays we are clearing with two punctures, one in the middle and one either upper or lower. We are able to clear with the punctures. And one other question that has come up is, I think probably this might be the last question. Um, when you do plan for a functional study in a renal stone disease?
again. It is previously he has told we'll do a CT scan to assess the function of the kidney. So it is not right. You are not supposed to do a CT as a guide to assess the function of the kidney, because even non-visualized kidney, even in IVU or CT, because of lot of other causes also. Even acute infection, you may not see the contrast draining. Again, it is mainly for a medical legal purpose. If you are dealing with an thinking that it is a clearly a poorly functioning kidney, if the patient wants to know how much functional improvement patient is going to get after the surgery, it is better to get in this thing. If it is like there is no hydronephrosis and it's good parenchyma, I don't think functional study make any difference.
So, Prashant, you would like to say that if the clinician has got a strong suspicion whether this is a good functioning kidney or not a good functioning kidney, better to document this before I go in for either an ablative surgery or a removal of the stone.
Definitely. That is a better this thing.
Good. Ranjan sir, your take on it, sir? This is probably the last question of the day.
Yeah,
Then we
I
do a
think
functional study
functional
first.
study, if what he has said is right, functional study may be necessary just to save the skin most of the time. Clinically, to get a surprise is not very common. As we have seen over the years, to get a surprise in functional study, which we are not expecting clinically from other evaluation, is not very common. But in spite of that, at times, if you can understand that this particular situation, which is in the borderline, whether we should salvage or we should remove it, then in that case it is effective.
Even some occasion it can be a harmful also. You have
Yeah.
done you have done a functional study. After multiple punches, kidney might have gone for a toss, and then you
Yeah.
end up in the other side of the.
Yeah. So it is more difficult to assess to give a straight cut answer for that.
Yeah, and I think the other indication, as we discussed, is for a stack on calculus where we don't want to operate, we put in a conservative management. For a follow up, you might require a functional study. There is one other question that has come from Dr. Tarangan from Patna. He has asked, is 24-hour urine analysis necessary for all stone cases? Prashant?
Yes, sir. Sir, it is ideally speaking, the recurrent stone formers requires a evaluation. There is no doubt about that. But if you ask the urologist, I don't think anybody is doing that because it is really a tedious job. And finally, end of the day, after knowing whether it is an hyperoxaluria, hypocytituria, or hypercalciuria, you are not going to treat that at all. So I think in a pediatric stone disease, I think it is useful. And if you are suspecting an RTA, renal tubular acidosis, and that type of cases, it might be useful. Other than that, I don't think it is more of an academic interest rather than doing all these studies. That's my
Correct.
take on it.
Actually, from a theoretical point of view, when they have a recurrent stone formation or they have anatomically abnormal kidneys, or when it happens to be a child with this thing, or patient has other abnormalities like diarrhea, I think you have a list of diseases in Campbell where you have to go for this 24 hours urine analysis. But practically for us, we don't do it on all patients. But there are certain patients who come to us and ask, Doctor, why am I getting this again and again? These are patients who really require the 24 hours urine analysis. And the point which Dr. Prashant has made is, even if you do, there is 50% chance that you will not get anything. And even if you get anything, you are not going to manage it. So these are the reasons why we don't do it as a routine. But as far as your exams is concerned, you have the list of 8 reasons why you do a 24 hours urine analysis that you will have to say in your exams. Yes. I think one more question has come up if we got time. Um, yeah, sir, in case when you do this procedure, have you ever encountered a retained guide wire piece and try to remove it or just leave it off? Dr. Sajal.
Recently, it is Dr. Sajal. I think sir can answer. We had one recently had one case which is where the guide wire is retained, and we have to do a RIRS next time. But the problem is that guide wire was, when we did an retrograde study, we found out that it is in the parenchyma, so we can't do anything. We have to left the guide wire and okay about it.
Yes.
Most of the
Ranjan sir,
time, unless it is inside the parenchyma, in a large amount of the guide wire has gone inside the parenchyma, what you can do by the side of the guide wire, if you put a very Fort French ureteroscope up to the kidney, and while you are coming out, holding the guide wire at the highest point and try to with the crocodile forceps and just manipulate it, and not from outside, from inside, you may get a success. I had only once, that was not my case, it was somebody else's patient. He had this problem, one of my junior. He called me, so I was standing by the side. Because he did not have that Ford French URS, so I took mine. So he inserted the ureteroscope by the side of the guide wire and reached almost beyond inside the pelvis, and holding it with the forceps, the guide wire, and by manipulating he could dislodge the guide wire. That was one of the experience I had.
Sir, one more point I want to add is, see how to avoid it. See, that is why, because always use a new thermo guide wire. That is the one thing. Another
Yeah.
one, when you are puncturing, no, it is most of the time that the puncture needle, and you are not maintaining in a straight line. You usually try to angle it, then it automatically what is happens is that the outer coating will get torn off.
Yeah,
This is
yeah.
the main issue with that.
But most of the time, you have to be patient and look that there is no extra bleeding while you are manipulating the removal. Otherwise, you can leave it with the written information that it got stuck inside. Later on, if necessary, we'll do RIRS and take it out.
One other question from Dr. Saju. If we have an apicalesial or any calesial diverticula, what will be your mode of treatment, sir? RIRS or PCNL?
RIRS is a better one. It is
Yeah,
always a
it will.
better approach rather than this thing, because what is happens is in a PCNL, if you do a mini PCNL or micro PCNL, whatever it is you are not able to enter into the system. If it is a completely cut off, it might be becomes a little bit blind. This thing. If there is a this thing, you can pass a guide wire and you can cut it with the laser and try to enter the diverticulum. That will be a more better option rather than a PCNL.
Great. Great. And I think probably we'll take this as the last question asked by Dr. Subramanian. Which technique would you prefer? Bullseye, triangulation? I think it's more of the surgeon's choice, how he got trained and how he is good in.
I think, sir, if you are starting at a bullseye is the most easiest way to do. So once you practice bullseye, then you can slowly change it to a gradual descent. It is even more this thing. Initially, I think when you are starting your career, the easiest way to puncture a kidney is bullseye. There is no doubt about that.
Exactly,
And
exactly. And even
all surgeons should be conversant with at least two methods of puncturing, because at times in bad days one particular method may fail to reach the calyx in a proper way. So it's always better to know at least two techniques. By chance it's not giving you the result, go for the other one and never come out without a puncture.
perfect, perfect. And PCNL is basically looking at a two-dimensional image and imagining it as a three-dimensional image. So
Yeah.
your each one brain is different. Each one temporal cortex is different. The way you have practiced yourself and your brain accustoms is better. Triangulation comfortable, triangulation, bullseye comfortable, bullseye. And as Ranjan sir says, you should be able to know both the methods in circumference situations. I know a lot of PCNL surgeons who never converted themselves from prone to supine, in spite of the supine advantages, because they are comfortable with prone and they can give the good clearance in prone. I think PCNL
Sorry,
is
I am one of them. I am one of them because I find PCNL in position very comfortable and simple. I recently I have seen one supine PCNL. I was called when patient has real problem. After 4 days, patient has a jejunal injury. You know,
yes.
so I've seen that. It has. I will see this year in the USA podium. This paper will come up. There was a jejunal injury. And number two, I know you may be doing it very regularly. The dilatation is little easier in PCNL.
Yeah, that I agree.
Dilatation is a little comfortably. You can dilate. Single step is you can dilate is more comfortable in the PCNL.
Correct. So the angle of your hand movement is more comfortable to dilate in a prone rather than doing in supine
Out
PCNL.
of actually, I am telling you, whatever puncture you make, supine or prone, idea is to give relief to the patient with minimal access surgery. And where you are comfortable with supine, you do it in supine. Where you are comfortable with prone, you do it prone. There is nothing big in either.
Perfect, perfect. So today we had a 60-year-old female patient who presented to us with the right side partial stagnant calculus and a left side ureterical without a dilatation. We know that we have been seeing stone patients with a younger age group, but our textbook always describes the ideal age or the higher age of presentation is usually around 50 to 60. This is because as the age becomes higher and higher, these patients are prone to develop urinary tract infections. These patients are prone to have hypercalciuria and hyperoxaluria and hypocytaturia, and these patients have metabolic syndrome, diabetes, hypertension, everything comes in. This is one of the reasons why elderly people present to you with stones, especially stagnant calculi. So when such a situation comes, we have to make a call whether we have to intervene with the stagnant calculi or not. We have decided since the life expectancy of the patient is good, we'll go for intervention in spite of the patient is asymptomatic. If we have to follow up, we have to do an urine culture, you have to do an urine routine, a renal function test, as well as a functional study for this patient for a follow up on the right side. On the left side, rightly, we decided to go ahead and clear an URS. I think a lot of discussions came, Dr. Prasant and Ranjan. It was wonderful on part of you, because as the discussions went on, initially there were no questions. The questions started flowing in. A lot of doubts came to our people, and with your experience, you have cleared a lot of doubts to our candidates. Thank you, Dr. Ranjan sir, and thank you, Dr. Prashant. You have been wonderful examiners to us, and we are having these programs on a regular basis. Maybe till the exams of the PGs comes, it will be more regular. After that, we'll slow down. And anyway, you'll be part of us as and when we have an opportunity to take you, we'll take you back again. I think you'll be happy to come again with us and join. So it is wonderful,
Thank you.
wonderful to have you with this.
Thank you very much. Thank you to the students, those who have participated, also those who have listened and put questions, and also to my colleagues. Thank you
Yes.
very much.
Thank you.
Apsa and Murugesan, actually, we have shown them the PPT only yesterday. So they were also ready to some, yes, sir, we'll also come and join you for this program. I should thank Afsa and Murugesan for coming on a short note and joining for this program, as well as Surender and Salman, who have been with us projecting the screen, and Sounder and the rest of the Mankind team. Prashant, this is Mankind Pharma, who are not very familiar with urology actually. They are good in other things, and now they have come up into the urology field. They started this program. They started to help me out. When I asked for help from one of the pharma, Mankind said, "Can you use our platform?" Now they're doing a wonderful job in this, and we hope they'll continue this urological help for us, for other teams also when it is required. Once again, thank you, Prashant. Thank you, Ranjan sir. Wonderful time we had, 1.5 to 2 hours. We really enjoyed the time with you.
Thank you.
Thank you very much.
Thank you. Thank you.
Thank you, sir.
Thank you. Thank you. Yeah, thank you. Thank you, everyone. Thank you, everyone.
Thank you, sir.
Yes, sir. Yes, sir. Yes, sir. Some final closing, but somebody wanted to say. Ranjan sir wanted to say something. Ranjan sir, your blessings be required.
No, it's all right. I just want to say thank to all my juniors and also my colleagues. That's
Sure,
it.
Ranjan sir, and many congratulations for taking over as the president of the ISO.
Thank you very much once again.
Thank you, everyone. Thank you, everyone. Good night. And this program will also be uploaded in the YouTube shortly, and we'll continue to have our programs as the days go by. Thank you.